And for Dr. Leal, after 2 years of Alectinib, the question here is around a solitary osteolytic spot in the spine. Is this progression, for a solitary progression, can they see on the drug? Is a change in TKI needed? And then for Dr. Iyengar, what is your thinking around treatments of oligo bone metastases vis-a-vis visceral? And so maybe we can start with Dr. Leal.
For the patient who's doing well on Alectinib and has, tolerated it well, I would confirm this is a site of a oligometastatic progression, doing PET-CT and further imaging of the brain, making sure there's no CNS progression. I would then talk to Dr. Iyengar about, hey, can you ablate this lesion and continue on the Alectinib, and certainly keep close eye and monitor the course and patient symptoms following radiation, but would continue on Alectinib, and that wouldn't necessarily trigger an immediate switch, although would have that discussion that perhaps we are, at the point of requiring switch in the future.
And I concur. I think, we know, I think as a field and as patients that, every subsequent line of therapy may be a little bit less effective than the previous line of therapy. So whatever we can do to maintain the patients on the current line of therapy, I think is the best resource. So we are happy to treat bone mets. We're happy to treat visceral mets. We're happy to treat brain mets, as long as we think that there is a rationalization of keeping the patients on the systemic therapy. Now we have to look at the kinetics of subsequent recurrences. If the patient has 5 more mets in a month, then probably the local therapy was less than ideal unless it was for palliation. But if we can get 6 months, 8 months, 10 months, I think that's really the way to go. Again, we can't predict. So right now we're probably opting to give the patient the benefit of the doubt and treating with local therapy.